Hi, I'm Andy Cheetham, nuclear medicine technologist and clinical tutor at King's College Hospital. I'm going to talk to you today about establishing local diagnostic reference levels for the CT component of a SPECT-CT study. But first, I'd like to thank my colleagues who assisted with this work. I'm sure that you already appreciate that there is a legislative requirement to establish diagnostic reference levels, known as DRLs. As can be seen from the medical and dental guidance notes, this requirement is the duty of the employer. In nuclear medicine, for the administration of radioactive substances, we are used to using national DRLs from the RSAC notes for guidance as a template for our own local DRLs. However, this method doesn't really work for the CT component, and so departments need to calculate their own values. National DRLs can then be derived from those local values. CT, as part of a SPECT-CT study, can be used for a number of different purposes. If the CT is only to be used for attenuation correction, then it is possible to set the parameters such that there is a very low radiation dose. If you want to use it to localize the uptake seen in the SPECT study, then you may use a slightly high radiation dose. Diagnostic studies, with or without contrast, allow you to characterize the tissue, but at the cost of an even much higher radiation dose. The use of diagnostic CT levels are increasing, with a move towards the concept of a one-stop shop. While this increases the radiation dose from a SPECT-CT study, it may actually reduce the overall dose to the patient due to the reduction in the number of imaging procedures performed on that patient. At King's, CT parameters are set either for localization or as a diagnostic CT without contrast. Two values are used in CT to describe the radiation dose: the CT dose index, CTDI, and the dose length product, DLP. The CTDI is the average radiation dose imparted to a standard 100mm pencil chamber dosimeter in milligrays, when this is measured in a phantom, which typically for a body would be 32 centimeters in diameter. It should be noted that this dose is not based on the size of the patient, but is based on the tube settings. This means that for a larger patient, if there is no tube modulation, and the tube settings will remain the same. As the CTDI is the dose to a phantom based on these tube settings, it follows that the CTDI will not change. However, the radiation dose to the patient will decrease. This is because the size of the patient has increased, and the absorbed dose in milligray is of course determined by the amount of energy deposited in each kilogram of tissue. A larger patient means a greater mass of tissue for the radiation energy to be deposited in. The situation is different if tube modulation is used. In this case, when scanning a larger patient, the CT tube settings will increase. Therefore, the CTDI will go up. The effect on patient dose will be determined by how closely the increase in tube settings matches the increase in patient size. The bottom line to all of this is that CTDI is only useful for comparing radiation doses if we know the weight of the patient and compare doses based on patient cohorts with standardized weights. The other measure I've mentioned, the dose length product, DLP, is based on the CTDI and the scan length. This value is thus heavily dependent upon the operator's choice in setting the limits for scanning the patient. So the aim of our study is to establish local diagnostic reference levels for the CT component of common SPECT-CT studies. Over the course of 2 years, over 1,000 SPECT-CT studies were examined. For each of the different scan procedures, the CTDI and DLP were recorded, as well as the patient's weight and the anatomical area covered by the CT scan volume. Studies were then categorized according to the scan procedure and the anatomical location. For each of these categories, DRLs were calculated using the methodology described in IPEM Report 88. Only patients weighing 70 kilos plus or minus 20 kilos were included, and the mean of these patients had to be within 70 kilos plus or minus 5 kilos. The DRL is then described as the median value of these group of patients. For neuroendocrine studies, indemoxatide, iodine 123 MIBG, and lutetium-177 dotatate, the CT scanning procedures used are all exactly the same. We wanted to include these all within one category. Looking at this graph, it is clear that the CTDI is not affected by the different scan procedures, and they appear to be a homogeneous group of patient studies. Equally, the DLP does not appear to be dependent upon this type of scan procedure, that is the administered radioactive tracer. However, looking at the DLP, it is not clear that the patient scans can be considered as one group. If instead we divide the neuroendocrine studies based on the scan volume, then it is clear that there are three different groups, which can be defined by the number of SPECT-CT beds. Those groups are abdo-pelvis, chest abdo-pelvis, and head chest abdo-pelvis. You can see here the locally derived DRLs for neuroendocrine studies. As you can see, the DRL changes with the number of SPECT-CT scan beds, especially when we consider the DLP. If we look at bone scans, a variety of different CT scan parameters are used. This appears to be a heterogeneous group with the dose based not only on the CT scan procedure, but also the anatomical location. It thus seems that it is not possible to define a single DRL for all different types of bone scans. If we consider only the low-dose CT scan for attenuation correction and localization when used for imaging the torso, then a clear pattern arises, with the CTDI increasing with patient weight. A DRL can therefore be determined for this homogeneous group of studies. Equally, when imaging the feet, we use a diagnostic quality CT. This dose does not increase with the patient weight, partly that feet don't really change in size based on that much on weight. Again, it is possible to create a DRL for this study. Again, if we look at another subset of bone scans, in this case diagnostic level CT studies of the lumbar spine, it is clear that we should be able to produce a DRL for this group as well. You can see here the DRL for a variety of bone scans. Whilst the overall DRL for bone scans is 10.2 milligray for the CTDI and 400 for the DLP, there is a range of values depending on the anatomical location and the choice of CT scan parameters. Shown here are some more values for other bone scans. Again, you should note that the value for all bone scans is not really representative. SPECT-CT is used in hepato-biliary imaging studies to establish the location of a bile leak. It is also used for localizing uptake in iodine 131 post-therapy studies for thyrocarcinoma. And indeed, you can see we've also used it for parathyroid imaging. For each of these, we've produced our own local DRLs. National DRLs have been released. Comparing our own values with these national DRLs, it can be seen that neuroendocrine studies and post-therapy I131 scans are well within those that are recommended. For parathyroid studies, a CTDI DRL is fine, but the DLP is a little higher at 196 compared to the national value of 170 milligray centimeters. This is because our own parathyroid protocol includes two SPECT-CT studies at one at 20 minutes and one at 2 hours post-injection. Equally for bone scans, you can see that we're again above the nationally recommended DRLs. But as I've explained earlier, this is based upon the case mix of the studies that we're performing. So to conclude, we have established diagnostic reference levels for a variety of nuclear medicine SPECT-CT procedures. We've compared these to national values, and we will use these values in the future for optimizing our SPECT-CT studies. Thank you for listening. I hope this talk was useful for you. If you want further information, please get in touch.